Welcome to the Hoover Virtual Policy Briefing Series. I'm Tom Gilligan, Director of the Hoover Institution. The principles of individual economic and political freedom, private enterprise, and limited representative government were fundamental to the vision of our founder, Herbert Hoover, and remain as compelling today as they were more than a century ago. A preeminent research center, the institution has remained steadfast in its commitment to finding solutions grounded in history, data, and logic to the many difficult challenges we face. The dissemination of our work has led to significant impacts on important public policy initiatives here and around the world. These briefings provide an opportunity to hear directly from some of our distinguished scholars on a wide range of domestic and international issues. Thank you for joining us, and I hope you find today's discussion valuable. As a reminder, we will be taking audience questions, and I encourage you to submit yours using the Q&A button located at the bottom of your screen. Today's discussion is with healthcare scholar Kate Bundorf. Kate is a senior fellow at the Hoover Institution, an associate professor of health research and policy at the Stanford University School of Medicine, a Stanford Health Policy Fellow, and a senior fellow at the Stanford Institute for Economics and Policy Research. She is also a research associate at the National Bureau of Economic Research. Kate, welcome and thanks for joining us today.
Thank you so much for having me, Tom.
Great. Kate, your specialty is hospitals and doctors, basically. Tell us how the pandemic has affected hospitals and physicians.
Well, Tom, it's been a really, kind of dramatic and interesting process, right? So, and you can really kind of think of it as two separate worlds of healthcare providers. And one world we saw on TV or in the news, and that was the world of hospitals that were essentially kind of overrun by COVID patients. This is mostly New York, and we think about hospitals, having lots of patients, worries about them being inadequately staffed, running out of ventilators and PPE. So that was, obviously an incredibly important and big issue that hit those folks. But then there was another world of healthcare providers that kind of had the other problem, right? And that was a very dramatic drop in demand for their services. Of course, we know that hospitals were advised or instructed to postpone elective procedures, but really and they did, and that explains part of it. But anecdotal reports, during the beginning of the pandemic started coming out that it wasn't just the elective procedures. It seemed like there were, fewer strokes, there were fewer heart attacks, there were fewer cancer patients. So it seemed like it went beyond those elective procedures. Even when we think about office-based visits, there was a report that came out showing that, from the beginning of the pandemic over the first couple months to the peak of the declined about 60 to 70%. The CDC just came out with data fairly recently showing that there is a 40% decline in ED visits, right? So people were not, for other healthcare providers, people were not coming in to see their physician, or maybe physicians were reluctant to bring patients in, during this time period. And this is really important, right? It's important for two reasons, right? So this is because these providers get paid fee for service. This has a financially devastating impact for many of them, right? If you're not providing services, you don't get fees, right? So a 60 to 70% drop in your visits is a huge shock to your revenue. It's also important in thinking about patient health, right? So, sometimes we worry about the services that we don't provide aren't high value and aren't particularly effective. Oftentimes they are very effective, right? So the key issue here going forward, or one of the key research issues and delivery issues, is trying to, figure out which of those services, types of services weren't being provided and getting those patients back in the door.
Yeah. Kate, help me put some numbers on these categories. You said there was one category of hospital that was overrun with treating COVID-19 patients. There was another category of hospital that basically sat dormant for 4 to 8 weeks as it made itself available to deal with COVID patients. Can you give me relative percentages of those two groups?
Yeah, I would love to, Tom, but I really can't, right? So I think that I will go out on a limb here and say I think there were more of I can't remember whether it was the former or the latter. There were probably more that over-prepared in the sense that they were dormant, and fewer that were really in crisis mode. and inundated with with patients.
Yeah, got it. I was struck by your statistics about the decline in office visits and emergency room visits. I think I'm not a physician. What would cause emergency room visits to decline? Is it just that people weren't going to work or they weren't driving as much, or do we know what drove that decline in emergency room visits?
Yeah, I think that's a great question. We're still early in the data surrounding the pandemic, and that's a fantastic question. So you can think of, a couple different channels by which this might happen, right? So as you said, we're driving less and, maybe going outside less, maybe undertaking fewer risky activities. So maybe we just didn't need those emergency room visits. We weren't getting in accidents, and, that explanation. The other explanation, which is kind of more worrisome for patient health, is, serious things were happening to me, for example, and I was nervous. I was, sitting at home feeling sick, but being, concerned that if I went to the emergency department, I was possibly exposing myself to COVID, at a time when we really didn't know that much about the disease. So I think we're still just trying to disentangle. And then I guess a third category is often, and prior to the pandemic, some people use the emergency room as their primary source of care, right, for primary care services. And, for those folks, maybe, they decided that it probably wasn't a great idea at this time to use it in that way. So I think we're just at the beginning of disentangling, what was happening there and, what were the impacts on patients.
Yeah. Kate, I probably know the answer to this, but is there any evidence yet, or do we know whether the lockdown and the shutdown or the unavailability of healthcare delivery during this period of time has led to bad health outcomes for people?
I think we just don't know yet. And there are, we've already talked about, a couple different channels, right, that would suggest that, we're not sure what the ultimate impact would be. A couple other things that we haven't talked about, there's some evidence that kids that were supposed to be vaccinated weren't getting their vaccine, their shots, right? So that's, something that we worry about in the long term. So on most of these stories, really another thing is how long will this drop last, right? So if this is a very short-term drop, and the study I referenced with this 70% decline, a follow-up study there showed that office visits were starting to increase. That's consistent with what the folks at Stanford are saying, that their outpatient visits are coming back and they're starting to get people in the door. If healthcare use comes back quickly, especially for the patients, for whom these visits are really important, then the impact on health will be lower, right? If people are still nervous, about coming in and seeing their healthcare provider, and even if the doors are open, people aren't going, that could have more severe implications for our health.
Yeah, interesting. If you're just joining us, I'm Tom Gilligan, and this is the Hoover Institution's virtual policy briefing with Kate Bundorf. Kate, some states are reporting increases in cases. Is this just going to lead to another wave of a hospital capacity being allocated across the competing demands of treating COVID-19 or providing and delivering ordinary healthcare services?
Yeah, once again, I think we don't know what is our, when we look at hospital cases, if we look at COVID cases, we're always thinking about the relationship to COVID testing, right? So as COVID testing goes up, we might get, it seems like we would have more cases, not because there are actually more cases, but because we found more cases, right? So I think, we want to pay attention to the number of cases. We want to keep that issue in the back, or maybe even in the front of our minds when we're looking at that data. But probably what is a better marker is when we start to see hospitalizations increase, right? Then we have a better sense of what's going on. The challenge, for the development of policy, especially around shelter in place and, opening the economy, is that hospitals are a lagging indicator, after cases, right? So we have to wait a little longer, and the infection rates are a little more advanced by the time we see by this time we see the hospitalizations increasing.
Yeah. So kind of look, from this current perspective, really close to the original outbreak of the pandemic, what lessons do you think we've learned, and how can hospitals and physicians be better prepared moving forward for the kind of challenges that a pandemic or an emerging or a second wave of the pandemic would have for us?
Yeah, so I think it's important to kind of think about the a second wave versus kind of a next pandemic. So let's think a little bit about a second wave. I think that hospitals and healthcare providers have learned a ton, right? So they responded to the first wave, figured out how to deliver care. If you look at the academic literature on thinking about looking at how to treat patients, right? Like things have exploded, right? And there's been a huge movement forward in understanding with the resources that we have right now. We don't have the treatments that we would want, but there has been a lot of learning on how to manage these patients. I think there has also been a lot of learning on the part of hospitals in particular on how to manage a surge, right? The hospitals that experienced the surge, clearly they learned a lot, and they share those lessons with the hospitals that didn't. And even the hospitals that didn't, there was a lot of effort that went into thinking about, well, how do I convert beds, right? How do I make sure that I can respond quickly to an increase in cases, right? So I think that on the delivery side, hopefully we won't have, surges, but, if we do, I think we will be better prepared for those. In the longer term, I think we obviously need to, once we're through this crisis, sit down and rethink, how we're going to respond to the next crisis. And, I think there's a lot of, well, hopefully we won't have a next pandemic very soon, right? So let's just put that out there. But, the next time we do, we are probably better positioned to think about all the policy trade-offs and the ways that we're going to respond, if only because we have more evidence now, right? And we can incorporate that evidence into our decision-making.
Yeah. We have a question from Christian who asked, why did so many states vastly overestimate the amount of people that would need hospital beds during the pandemic?
So to be straightforward, right, like I don't know, but it would, I would say that there was an incredible amount of uncertainty, right? And, if you look at New York, versus other areas of the country, I think that, places were not sure whether they were going to be New York or whether they were going to be, Palo Alto, for example. So I think that uncertainty, in the face of that uncertainty, folks had to make plans, right? So, and they basically planned for the worst.
Yeah, got it. And the evidence around the world was highly variable as well. Italy and other countries being examples of bad cases.
Exactly.
Got it. If you just joined us, you're listening to Hoover Senior Fellow Kate Bundorf. You can find more research by Hoover Fellows at our website, hoover.org. Kate, we've talked a little bit about the delivery of healthcare. What about insurance markets? How did COVID-19 impact the health insurance market?
Yeah. So the kind of the elephant in the room for insurance markets is unemployment, right? So as many folks probably know, employment is really the backbone of our system for the working age population. Most people who have health insurance who are under 65 have it through an employer. Mm-hmm. So that is, that creates a tension, right? Because when you, if you have your health insurance through an employer, when you lose your job, as many people did, we had a huge, historic increase in unemployment at the beginning of the COVID pandemic. If you don't have your job, you don't have your health insurance. Yeah. I think one thing that is, people are a little bit often unaware of is actually the kind of the dollar value of the insurance that they have from their employer. So the average premium for employer-sponsored health insurance for a family plan now is, just a bit over $20,000. So when you think about losing your job, not only do you lose your wage, but you also, if you had a family plan, lose $20,000 worth of health insurance. Yeah. Employment insurance is, focused on your wages. That leaves, a health insurance as, a separate set of programs. right? So uninsurance is really accompanied, or unemployment really, can lead to high levels of uninsurance.
Yeah. Was there anything in the CARES Act? I know the CARES Act, for example, provided a subsidy to state-funded unemployment insurance. Was there a subsidy for paying for health insurance by people who were newly unemployed?
Yeah, so this is the really thinking about policy in this area really kind of takes you down the rabbit hole of the very tricky and Byzantine aspects of our health insurance system, right? So let's think of a couple examples. So one is if the funding in the CARES Act caused your employer to keep you employed, right?
Yeah.
Then you might still have your health insurance. If your employer didn't keep you on, the mechanisms, were less direct and not explicitly related to the CARES Act. If your employer, if you actually lose your job, you have a couple options facing you. So one is that you could continue your employer-sponsored health insurance on your own, right? That means that if I will make a payment to my former employer for keeping that coverage I had, that payment is the premium that the employer paid on my behalf when I had employer-sponsored health insurance, plus a small percentage for an administrative fee. So if I've lost my job, that's a pretty good chunk of change, right? If I'm going to do that, if I'm going to feel like I can afford that, that's probably in part based on my expectations of reemployment and what's going to happen, right? Is this a permanent, a very long-lasting income shock for me, or is this just going to be a little bump in the road? There are, in the last recession, we know in the Great Recession, a lot of people lost their coverage, but things are different now. We have the Affordable Care Act, and we have, a system of states that expanded Medicaid, and all states across the country that adopted health insurance exchanges. That creates another set of mechanisms. It's basically a safety net, a set of choices that we didn't have in the last recession, and those are other places that folks who lose their job can buy health insurance.
Mm-hmm. And is there a funding mechanism to subsidize the purchase of health insurance in those, either ACA or Medicaid or another exchange?
Yeah, that's a great question. So once again, as in all things in health insurance, this is complicated.
Yeah.
So let's start, kind of at the top and think about COBRA. COBRA generally is not subsidized, right? In the last recession, Congress passed a law that allowed for 65% subsidization of COBRA coverage. And my understanding is that is something that is currently under discussion now. Would there be a subsidy? Will there be a subsidy? And how big will that subsidy be? How big will that subsidy be? When people buy coverage in the exchange, they may get a subsidy. The extent to which they get a subsidy is dependent on their income. If they have higher levels of income, close to 400% of poverty, for example, that is a smaller subsidy. But if they're closer to, say, 1.5 times, their income is closer to 1.5 times the poverty level, they get a larger subsidy. One thing that's important to note about the exchanges is that if you're going to buy coverage in an exchange, if you lose your employer-sponsored coverage, you're eligible. Usually you'd have to wait for the next open enrollment period, but you'd be eligible if you lose your employer-sponsored coverage, but you're eligible for a short window of time, right? So some states have opened that up, others haven't. That's one thing to, that's to check out and keep in mind if you're thinking of that as a mechanism.
I see.
Medicaid is designed for people who have the lowest levels of income. Medicaid does not have, you can sign up for Medicaid anytime and become eligible, if your state has expanded its Medicaid program. And, you don't have to wait for a particular, you don't have to do it within a particular period of time. You can sign up whenever you're income eligible.
Yeah. Kate, I have a couple questions from Mark and Leonard. They're the same question, which is, are there any projections about how many people have or are likely to lose their insurance coverage, and what that, and Mark kind of wants to know what that effect will have on hospital physician revenue as well as overall population health?
Yeah, these are great questions. I'm feeling a little bit bad because I don't have the number off the top of my head, but let's say it's Probably the best place to look for this right now is there is a report from the Urban Institute, and they have, a health insurance simulation model, and they cranked up their model, and they, they figured out the number of people that they thought were likely to lose their health insurance. And then they also, tried to do some simulations on the number of people that would enroll in these different types of coverage, right? And, don't quote me on this, I'm ballparking this, but let's say roughly like a third, like a third might end up in Medicaid, a third might end up in exchanges, and a third of those people who lost their coverage might end up uninsured. Once again, if you want the very precise estimates, we'll go to the Urban Institute report and look at it. But the second point in the person with the question made is also really important, right? So as we are shifting sources of coverage across the population, in general, we're shifting people out of private health insurance, and we're shifting people into Medicaid and exchange coverage. Rates of payment to healthcare providers are much higher from private health insurance than they are from certainly from Medicaid, and even from Medicare or exchange plans tend to have lower payments on average as well. And those, and those differences can often be very big, right? So this is kind of a second order stress on healthcare providers as well, right? So if you're a hospital or you're a physician, now if a large portion of your patients or a substantive portion of your patients are shifting from private health insurance to Medicaid, that means you're getting lower payment rates for the care that you provide to all those patients. So that is an important change and a potentially important stress for the healthcare system as well.
To put some numbers on this there, if I get this, if I recall, I think there are just short of 40 million new unemployment claims since the pandemic started. So you're thinking about a third are uninsured, a third have gone into Medicaid?
As in all things in health insurance, not quite that simple, right? So, sorry. And I'll be quick, but let me just give you a sense of the complexity, right? So I am married. My spouse gets employer-sponsored health insurance from his job, let's say, and I lose my job. Some of the people might move into coverage from someone else in their family, right? Some people might be eligible for other other types of coverage. But let's say, roughly, maybe 75% of people are looking for something new, in the categories that we talked about, and maybe a third, end up in those three different categories.
Yeah.
Just being careful here, right, to not lock myself into an estimate.
No, I hear you. It's complex. And Joe kind of asked the following question, I guess, which is, why don't we make it less complex? She wonders, do you think that the loss of health insurance that's tied to unemployment will generate support for a bipartisan proposal for Medicare expansion or universal health care? In other words, I guess the problem is healthcare is tied to employment, and employment is the big problem. Just separate the link.
Yeah, so this is, I think this is a really important question, and this, the pandemic that we're in, or the pandemic and the associated recession that we're in now, is a really important test of our, of the ACA, essentially, right? So part of the reason, we put in place these safety net programs was, to make it easier when people, experience this kind of disruption in their lives. The complexity that we have here, I think, is an issue, right? In the short term, I feel strongly that we really need to kind of get the word out and help people understand, like today, right now, what are they eligible for and what are their options. I think that is incredibly important. And going forward, I think that we do have to think about ways to make these transitions a little bit easier, right? I'm not sure that would translate, I guess I should say, I think there are multiple ways to do that, right? And, you know, like a Medicare for all is not the only way to do that. You know, there are other steps that we could take about the way we create subsidies and the way subsidies move with people across different types of coverage. You know, there are ways to keep a competitive private health insurance and, you know, make it easier for folks to move in situations in which they, you know, experience these types of unanticipated events, right? So, you know, to kind of summarize, I think this issue is very important, and this is a place where we need, you know, to really kind of think about creative solutions, right, to address this.
Yeah. So are there any other problems that the pandemic is kind of shown light on? Are there any other problems in the healthcare system that the pandemic has uncovered?
Yeah, I mean, I think, you know, there are lots of good things and there are lots of problems in our healthcare system, and in many ways it's, you know, magnified many of those on both sides. I would say, you know, one thing that's kind of interesting to think about in the context of the pandemic is, I think that, you know, even before the pandemic, you know, many people, including myself, you know, believed that one of the things that would help our healthcare system or, you know, make it better is if we could shift providers towards, we could change basically the way that we pay providers, right? Instead of paying fee for service and instead of paying hospitals and physicians a fee for basically every admission or everything that we do, we could move towards, you know, what people often refer to as more value-based payment, right? We could, you know, pay at the population level per person, you know, and
Right.
design those very carefully to think about, you know, issues of selection and whatnot, but kind of shift providers away from volume, as people always say, and toward value. So if
Yeah.
we stop and we think about this in the context of the pandemic, this is actually really powerful, right? So take the example of a primary care physician. So a
Yep.
primary care physician is getting paid fee for service. And when, you know, when they experienced that drop in services, right, they experienced a direct drop in fees. They were getting paid nothing. If the
Mhm.
primary care physician were instead, you know, paid some sort of capitated payment per person enrolled in their panel, they would not have experienced, you know, that drop in revenue. The revenue would have kept coming from, you know, from the, you know, from the insurance company. So, you know, when so fee for service was good until there were no services, right? And then that was a problem. The other thing that I think is kind of really underappreciated here is, let's say that, you know, let's take the example of telehealth, right? So a very important thing that the Centers for Medicaid and Medicare Services did in the very beginning of the pandemic was say, we will pay for telehealth visits. And that was incredibly important, right? So people can't come in to get their visits. Now they can do telehealth. You know, there's lots of controversy over, you know, in what situations does telehealth work and when it doesn't. But, you know, I think it's pretty easy to see that if you can't or you shouldn't come in to see your healthcare provider, it probably has some benefits. But the you know, the way that was implemented, or what was a huge push in that movement, was the fact that CMS said, yes, I will pay for a telehealth visit, right? And that kind of opened the floodgates to telehealth visits. If hospitals and physicians were paid, let's stay with my primary care physician. If the primary care physician were paid by capitation, the primary care physician just could have done that, right, without CMS standing in the way, right? So I really think that these, you know, if we change the way that we pay healthcare providers, will change the incentives for innovation, and in many cases for the better, right? Providers will be more nimble. They'll be able to, you know, respond in ways that don't, you know, don't require getting a code, right, to get paid.
Yeah, interesting. Sticking with the idea of innovation, have you seen, you talked about telehealth, telemedicine growing and during this crisis. Are you seeing any other innovations that are taking place during this health care crisis? And is CMS supporting them through payment strategies and reimbursements?
Yeah, I think that is probably the most obvious one, you know, that came out that came out through CMS. I think that is, you know, as I said, the one that is kind of on everyone's minds. I think, if we think about innovation, hospitals and providers, they did lots of things behind the scenes, right, to change the way they were delivering care. And I think the way to think about that going forward is, can we adopt payment systems that really encourage that kind of innovation, right? So can we keep that going forward, whether through CMS, whether through private insurers? When you think, if we go back and we think about the private insurers had already charged premiums, right? And then healthcare use went down, right? So the people, normally the private insurers are at risk for the increase in healthcare use. That means that they benefit from the decline in healthcare use, right? So this was really, this kind of helped in some sense the bottom line of private insurers, but we have seen private insurers respond in ways that are helping the hospitals and more and to a larger degree the physicians with whom they contract, kind of weather this storm, right? So that's another example of the types of policies and private sector initiatives that have emerged as a result of the pandemic.
Yeah. David asked the following question. Might the current crisis lead to an equalization on the tax treatment of individually purchased medical insurance with corporate purchased?
It's a possibility. I think, economists, we're not often beloved, right? But economists have been talking about this for, I would say, probably 30, 40, 50 years. And it's generally a policy that economists are in favor of. So I suppose that is a possibility. I guess that's the type of thing that I would have in mind, if we recognize that we want to create a more, kind of equal a system of subsidization that treats, different sources of health insurance similarly. That's a perfect example of something that we would want to consider.
Yeah. Jefferson asked a question, will the current pandemic lead to more self-insurance?
Well, the current pandemic will lead to more self-insurance, right? So, the vast majority of large employers are already self-insured. So that there's not a lot of room for more there. And that, over time had kind of moved down through the distribution of firm size. So lots of firms are already self-insured. I'm not sure whether that will necessarily create more self-insurance, but that was already a trend that was in place, prior to the pandemic.
Yeah. Arthur asked the following question: does the majority of primary care physicians or organizations of such physicians support capitation payments rather than fee-for-service? If not, why not?
That's a interesting and deep question. I think that there are a couple things going on there, right? So if we think so let's array payments on a scale like fee for service is at one end and capitation is at the other. And I just want to make a point that there are some there's some payment systems in the middle, right? But for the sake of talking about this, we'll just talk about the two extremes. I think, prior to the pandemic, really, when healthcare expenditure, healthcare use was growing consistently over time, taking on a capitated payment for a primary care provider was basically being exposed to a bunch of risk, right? But people hadn't really thought about the risk in the form of the dramatic shock, drop in demand. Right. So the risk was, patients will use more care than I think they will use. Right. And, maybe I'll just end up with a bunch of really sick patients and a capitated payment would put me at risk. Right. So I think the pandemic has shown that there's a downside here too. Right. There's a different form of risk. Right. So maybe that will make primary care providers more receptive. On the other hand, right, if we think about, where is taking risk most appropriate, right? Well, part of it depends on the magnitude of the risk. We can think about a capitated payment for all the services that patients use, right? That is probably too risky for, a very small primary care organization. That's probably more appropriate for a large multi-specialty group, for example. Primary care physicians that work in small groups would probably be more receptive to payments that had a narrower bundle of services under the capitation, and maybe only their own office visits, something like that. So will this encourage more, more primary care physicians were reluctant prior to the pandemic. It may encourage them to be more receptive to that. I kind of hope so, but I have to say at the end of the day, I'm not sure.
Yeah. Scott asked the following question. Will the pandemic help push the insurance market to more of a high deductible model for individuals? In other words, having individuals have more skin in the game?
I don't know. Like, I don't see an obvious, reason why it would, as Scott probably knows, there has been an increase in the proportion of people enrolled in high deductible plans, generally over time, right? Especially in the last, 5 or so years, right? So the market had already been moved in that direction. I don't, I actually don't, I don't know if that will, push it, more in that direction or not.
Yeah, got it. Kate, you said earlier that it's, in many ways, this current pandemic and the resulting unemployment has been a stress test for the Affordable Care Act and the value in terms of portability of the exchanges and Medicaid options, et cetera. How would you grade the act in handling this challenge?
I hate to do this to you, Tom, but I'm going to say I don't know, all right, because I'm waiting for the data. Where are my, what are the things that I'm thinking about, right, in terms of, how the Affordable Care Act responded, or how well it did during this time. I think one thing is, how did people get into coverage, right? Like, do we have less uninsurance as the result of having the Affordable Care Act in place than we had in the last recession, right? So are people able to, get coverage, and is this working for folks? I think one of the people who wrote in a question, brought up a really good point about the shift of private payments to Medicaid.
Yeah.
If people shift their coverage from private coverage to Medicaid, for example, that will, and a lot of the expansions under the Affordable Care Act are in the form of Medicaid,
right.
that shift in payer source will create stress for healthcare providers. So that is another metric that I'd be looking at. If you think, when people move from their private health insurance to a Medicaid plan, what happens to their health? What happens to their access to the physicians? Are they able to get the kind of care that they need? That'll be another, metric that I would think about, and, trying to think about how the, Affordable Care Act responded, right? So did people get into their health insurance? How did it affect healthcare providers? Are they making these types of shifts in ways that are sustainable? And then at the end of the day, how did it affect people's healthcare?
Got it. Great. Kate, we've run out of time. I want to thank you for joining us today. What a wonderful discussion.
Okay. Thank you so much for having me, Tom.
Appreciate it. Our next Hoover virtual policy briefing will be Thursday, June 18th at 11 a.m. Pacific time and 2 p.m. Eastern time with Ayan Hirsi Ali, who will be talking about identity politics and its tribal branches. Ayan is a research fellow at the Hoover Institution and the founder of the AHA Foundation. She's a best-selling author and was also named one of Time Magazine's 100 Most Influential People of 2005. You can join Thursday's briefing at the same link that you signed in on today. And you will find the Hoover Institution online at hoover.org and on Twitter, Facebook, and Instagram. Again, thank you for tuning in today, and I hope to see you on Thursday. Goodbye.